Okay, you can start now.
Yes, sir.
Hello. Hello.
Hello.
Yeah. Yeah. Now it's audible. Yeah.
So can you see my slides?
Yes. Yes. Can see.
So transient vision loss is the sudden loss of visual function. It can be partial or complete in one or both the eyes that lasts less than 24 hours. So main important thing is history taking and then examination. History taking plays an important role in this condition. You should ask for if it is a monocular, binocular vision loss, age of the patient, duration of visual loss, pattern or description of visual loss and its recovery, associated symptoms and additional clinical features, and if the patient has any predisposing conditions. So coming to the first thing, monocular or binocular. So this is important to localize the causative lesion. Monocular loss can be prechiasmal. There can be a prechiasmal problem, which can be from anything from cornea to optic nerve. Binocular loss, usually there is a chiasmal or a retrochiasmal problem, which is an intracranial problem. Transient homonymous hemianopia is frequently misperceived as monocular vision loss in the eye with temporal visual field effect. Most common cause of monocular vision ischemia, and most common binocular transient vision loss is due to migraine. Amaurosis fugax refers specifically to a retinal transient ischemic attack, which is associated with an emboli. Then most common cause of monocular transient vision loss in older patient is because of cerebrovascular diseases. Central retinal artery vasospasm can cause monocular vision loss in young patients. In a patient who is older than 50 years of age, transient vision loss can be accompanied by symptoms such as headache or jaw claudication or scalp tenderness, which strongly suggest giant cell arteritis. And in pregnant women with eclampsia, transient vision loss is more serious as it can cause permanent vision loss, and it usually occurs within a few days of delivery. The duration of vision loss. Retinal ischemia, either from an emboli or giant cell arteritis, it is usually monocular transient vision loss, and it lasts for few minutes, and it is usually less than 15 minutes. Transient vision loss from central retinal artery vasospasm, it can be for few seconds or can extend up to an hour. Ocular hypoperfusion or venous insufficiency, it can last up to 30 minutes. Occipital seizures, there is brief binocular vision disturbances and it is only for few seconds. Binocular scintillating scotoma, it is typically seen in migraine and it lasts for 20 to 30 minutes. Then there is pattern or description of vision loss and there is a recovery pattern as well. So transient vision loss due to retinal emboli or a central retinal artery vasospasm, there is a descending or an ascending curtain-like pattern which is seen in one eye. There can also be a tunnel-like constriction or a sudden complete loss of vision. During exercise, particularly there is a vision loss. It occurs because of vasospasm or pigment dispersion syndrome or demyelinating disease. Udorf phenomenon, which is a transient visual loss resulting from physical activity or elevation in body temperature. It can be because of current or a previous episode of optic neuritis. Then posterior circulation ischemia, it is there is a complete binocular transient vision loss. There is a cortical visual impairment or a homonymous hemianopia with brainstem or cerebellar symptoms can be seen. Binocular visual disturbances with a geometric pattern, that is a fortification pattern. It is seen in occipital lobe dysfunction and is usually associated with migraine or ischemia or seizures. There can be positive visual phenomenon associated. Whiteout of the vision in both eyes or a gradual constriction, that is a closing in pattern of peripheral vision without any positive phenomenon, is seen in occipital lobe ischemias. So associated symptoms and additional clinical features. Binocular transient vision loss with focal weakness, with loss of consciousness, dizziness, that is difficulty in speech. Cerebral ischemia in the posterior circulation can be because of a problem in basilar artery territory. Then focal visual loss, focal weakness contralateral to monocular transient visual loss or aphasia is seen in cerebral ischemia in the anterior circulation, which is an internal carotid artery territory. Then same side periorbital pain with Horner syndrome indicates internal carotid artery dissection. And transient vision loss, which is associated with ocular discomfort or irritation, which improves with blinking, can be because of dry eye also. So this symptom is aggravated by activities that require prolonged concentration, or there is a prolonged screen time, or there is decreased blinking, such as during driving or using a computer or watching television. And this usually lasts for a few seconds. Then predisposing condition, if there is any presence of vascular risk factors, atheromatous diseases like carotid stenosis, coronary artery disease, peripheral arterial disease, aortic aneurysm, diabetes mellitus, hypertension, dyslipidemia, smoking, or sleep apnea, conditions suggesting a cardiac source of emboli, like a previous episode of myocardial infarction or any valvulopathy or arrhythmias. Then intravenous drug use, any family or personal history of clotting disorders, then systemic cancer or history of connective tissue disease or any vasculitis like giant cell or Takayasu arthritis. Examination part, corrected visual acuity, examination of pupils, slit lamp examination, automated perimetry, dilated ophthalmoscopic examination. A positive photostress recovery test may indicate macular ischemia, or when a vascular mechanism is suspected, retinal fluorescein angiography can also be done. So coming to a monocular transient visual loss, it can occur because of three main particular causes. The most commonly seen is the tear film abnormalities that is seen in dry eye patients. Then uveitis glaucoma hyphema syndrome, where there is anterior chamber abnormalities. In this case, you have to look for narrow angles, or if there's any IOL rubbing on the iris or any pigment dispersing. In posterior segment abnormalities, macular abnormalities or optic protrusions or optic nerve head swelling has to be examined. And coming to the orbital causes, there can be a foreign body or a tumor. A tumor, mainly meningioma or hemangioma, can be seen, for which an orbital examination and orbital imaging is needed. And coming to the vascular causes, most commonly it can be an emboli, which is seen in carotid, can have a carotid or a cardiac source, and clinical examination of pulse, blood pressure, cardiac, or a carotid auscultation is important. Then imaging such as MRI or MRA or CTA of head and neck plays an important role. Then carotid ultrasound also should be advised, and then blood test to see if the emboli has a cholesterol or glucose level abnormalities. Then coming to the vasculitis, in patients older than 50 years of age, giant cell arteritis is the first thing you have to rule out, for which ESR, CRP, and temporal artery biopsy can be advised. The hypoperfusion, very commonly seen in CRVO, ocular ischemic syndrome, or a stenosis of great vessel can be seen. Hyperviscosity or hypercoagulable state, which can be done by CBC, prothrombin time, and other clotting factors can be examined. Then in vasospasm, it is a diagnosis of exclusion. So in case of a monocular transient vision loss, first thing is you have to exclude if it is ocular or orbital cause. Then in patients of more than 50 years of age, giant cell arteritis has to be ruled out. Then work for a source of emboli, where is the origin, and if there is any CNS ischemia associated, has to be examined. So acute presentation, if there's clear history of transient vision loss with a visible emboli and a permanent defect, then you have to immediately refer the patient to an acute stroke or an emergency department. If not, then still a carotid artery duplex ultrasonography, MRI, MRA, CT, CTA has to be advised. Then transesophageal echocardiography and Holter's monitoring in case of arrhythmias. And if you're suspecting any emboli elsewhere, the blood pressure, cholesterol, or glucose examination plays a role. Test for hypercoagulable causes and test for collagen vascular disease are also advised. Then this picture shows different type of emboli. The first picture is of a cholesterol emboli, which is a yellow, orange, and copper colored emboli, which is globular in shape and is usually located at the major bifurcation. The source can be an internal carotid artery. The second one is a platelet fibrin emboli, which is a dull gray white color, which is a smooth and long shaped emboli with concave menisci. And usually it is associated in the wall of atherosclerotic vessels. Then the third one is a calcium emboli, which is a white colored large emboli. It is usually round or ovoid in shape and usually is present in the first or second bifurcation. Or it sometimes can be overlying the optic nerve head. And the source can also be associated with heart or great vessels. So in all these cases, when there is a visible emboli, a cardiac checkup has to be done. Invasive, non-invasive studies to see the patency of the vessels has to be carried out. In case you're suspecting a platelet fibrin emboli, then a hematological workup is also advised. The clinical or laboratory evaluation, transient vision loss, which is due to emboli, there is increased rate of morbidity and mortality from stroke, myocardial infarction, or aortic aneurysm. So clinical examination of pulse for atrial fibrillation and blood pressure, cardiac auscultation, and carotid artery auscultation, it is best done at the jaw, angle of the jaw where the bifurcation is located. Then the embolus is, if it is a visible, then a workup of giant cell arteritis is generally not necessary. Otherwise, if the age of the patient is more than 50 years of age, GCA has to be first ruled out, and then the workup of the source of emboli must be initiated. So why does it become important for us? It is because of the prognosis of the patient. So among the patients with transient visual loss, it is seen that significant carotid artery stenosis or occlusion is present in over 50% of the cases. Retinal is associated with risk of early ischemic cerebral stroke or other cardiovascular events. Of patients with transient ischemic attack, it can be retinal or a cerebral. 10 to 15% have a cerebral stroke within 90 days. And approximately 50% of these strokes occur within 48 hours. That's why an ocular examination which suspects where there is transient visual loss, systemic examination plays an important role. So guidelines for transient ischemic attack management. So according to American Heart Association guidelines, a patient who has had either a retinal or a cerebral TIA requires immediate assessment for an acute stroke. An acute stroke is diagnosed in abnormal neuroimaging. So normal MRI, which is evaluated within 24 hours in a stroke clinic or an emergency department observation unit affiliated with a stroke center, has to be done. And although the risk of stroke after a retinal transient ischemic attack related to carotid atherosclerosis is lower than that which is associated with cerebral TIA, the management of retinal TIAs is similar to that of the cerebral. So coming to the treatment part, medical treatment of retinal TIA due to carotid artery stenosis, antiplatelet agents like aspirin or the combination with dipyridamole or clopidogrel is advised. Anticoagulant therapy consisting of direct oral anticoagulants is used to prevent recurrent ischemic stroke in patients with atrial fibrillation. And along with warfarin, DOACs have now become a mainstay of anticoagulants. The only limiting factor is that there is increased risk of bleeding. Then vasculitis, it is a monocular transient vision loss in patients who are older than 50 years of age. And an impending acute or permanent vision loss in one or both the eyes. So this is called as an occult GCA. All patients older than 50 years who present with transient vision loss should be examined, should be investigated for ESR, CRP, and a complete blood count. If GCA is suspected, immediate treatment with high dose of corticosteroids should be started to prevent progression to permanent vision loss or a contralateral eye involvement. Then ocular hypoperfusion, it leads, there are three classic scenarios which lead to monocular transient vision loss. The first one is central retinal vein occlusion, then change in posture from sitting to a standing position, and an ocular ischemic syndrome. So CRVO, there is a transient vision loss which lasts for seconds to minutes, and then full recovery to normal vision can be seen. Some such symptoms may predate more lasting visual loss by days or weeks, or symptoms may stop when there is collateral vessel formation. Then there is change in posture from a sitting to a standing position. A monocular transient vision loss is usually related to severe stenosis of great vessels, or in case of GCA. There is progressive construction of vision loss in the periphery. There is diaphragm pattern that lasts from seconds to a couple of minutes. Then ocular ischemic syndrome, it is characterized by a hypotensive ischemic retinopathy with low retinal artery pressure, poor perfusion, mid-peripheral dot and blot retinal hemorrhages, and dilated non-tortuous retinal veins, which can cause venous stasis retinopathy. Recurrent orbit vein that improves when the patient lies down is highly suggestive of carotid occlusive disease. Then when there is severe ocular ischemia, it causes anterior segment changes that may be confused with chronic intraocular inflammations. So treatment includes ocular reperfusion via carotid endarterectomy and arterectomy or carotid stenting whenever it's possible, and use for neovascularization, including panretinal photocoagulation. If the preoperative IOP is low, restoration of the blood flow may precipitate dangerously high IOP. That's why IOP lowering drugs have to be advised. Ocular signs of chronic hypoperfusion develop if they in other patients, carotid occlusion may be advanced for surgical corrections. Thus, early detection is crucial because neovascularization and progressive ocular ischemia can result in prolonged hypoperfusion. Then coming to the vasospasm, hyperviscosity and hypercoagulable states, then there is monocular transient vision loss, and it can result from vasospasm of the central retinal artery. Young patients experience stereotypic episodes of painless, severe monocular transient vision loss. Vasospasm transient vision loss is a diagnosis of exclusion. Transient vision loss due to increased serum viscosity resulting from an elevated paraprotein levels is seen with multiple myeloma. Then transient vision loss due to increased red or white blood cells, as in polycythemia vera, leukemia, and a myeloproliferative disease can be seen. Then coming to the binocular transient vision loss, most commonly it is seen in migraine or in occipital mass lesion or in occipital ischemias. In case of migraine, this is the most common cause of binocular transient vision loss and is the homonymous hemianopic defect caused by migrainous visual aura. Small homonymous scotoma bounded by a zigzag or shimmery or colorful or silvery images can be seen. The scotoma enlarges over several minutes, sometimes to a complete homonymous hemianopia, and then gradually disappears. Vision typically returns to normal within 5 to 60 minutes, and the visual aura is followed by a headache. Typical aura with headache can also be seen in cephalogenic migraines. Then occipital mass lesion, a structural lesion such as an occipital arteriovenous malformation or tumor, may cause episodic binocular transient vision loss, which may be associated with headaches. Symptoms that always occur on the same side are highly suggestive of a structural abnormality. And in these cases, an MRI or an MRA is advised. In occipital ischemia, episodes of complete binocular transient vision loss may represent transient ischemic attack involving the occipital lobe, either in the distribution of an artery or a posterior cerebral arteries. Hemianopic events of ischemic origin are typically sudden in onset and last only a few minutes, and it can be associated with headaches, especially in contralateral to hemianopia, but the pain occurs at the time of transient vision loss. So this is international classification of headache disorders. They describe it as repeated attacks of monocular visual disturbances, including scintillations, scotomata, or blindness associated with migraine headache. The criteria is aura characterized by both of the following. The first one is fully reversible monocular positive or negative visual phenomenon, which is confirmed during an attack by either or both of the following, like clinical visual field examination or the patient's drawing of the monocular field defect. then at least two of the following, like the spreading gradually over 5 minutes, or the symptoms which last for 5 to 60 minutes, or it is accompanied or followed within 60 minutes by a headache. Then not better accounted for by another international headache society is 3 diagnosis and other causes of amaurosis fluid gaps. They need to be excluded. Thank you.
Yeah, good presentation. Any questions from anyone? So it's very important to make sure that systemic examination is properly done in case of transient vision loss. Monocular has said that commonly the origin is in the carotid or echo, like cardiac system or carotid Doppler. So that is a precursor for TIA or stroke. That should be properly checked. Important to remember the examination for ESR and CRP, because if it is a immunological disorder or collagen vascular disease like giant cell arthritis, it may cause other eye this thing also, arthritis, and can cause bilateral vision loss. So that should be kept in mind when our patient comes with uniocular and transient vision loss. And for binocular, commonly what we see is a migraine only. And recently there have been few cases because of overuse of mobiles also. It has been reported, commonly caused probably because of accommodative spasm, where patient says that there is a transient bilateral vision loss, sometimes for a prolonged duration. I think all other things are properly covered in the presentation. Any questions?
No, sir.
Okay, okay. We will end the presentation. Thank you.
Yes. Thank you, sir.